I think it's appropriate to start this discussion with a hug, Ali, between you and I. We've been, first of all, it's an honor to be here. Thank you very much for the kind invitation. Before preparing for this lecture, I actually went back and looked at the contribution Dr. Crawford made to the art in the field, and I hope that this important overview of multiple disciplines would meet what he had in mind when he put this together. I have this conflict statement, but nothing related to what I'm going to be talking about today. I'm going to take a little bit of a different tack on this. I often am asked by cardiology fellows, what do I need to do to get vascular interventional privileges? And it used to bother me to get that question because when I finished my interventional year in 1992, cardiac intervention, the last thing I wanted to do was a vascular medicine and interventional fellowship another year. In fact, I tried to negotiate myself down to 6 months, but what I found was a year really wasn't enough. And so that kind of bothers me, and I used to have difficulty responding to that. I've shifted now to this Simon Sinek kind of golden circle view on this. So I tell the fellow, you're starting with the wrong question. If you're starting with what, getting privileges, then it leads to how, which means number of cases, and ultimately it gets down to the why, and they don't really know except we want to be more marketable. That's not a good reason to get into this field because that minimal training, I think, translates to confirmation bias and some challenges that can impact outcomes. And not only that, the RVU focus and all these things, I can tell you, all of these are false summits. They don't really mean anything. So the key, I think, is to start with why. So I bring back going from the inside of this circle outward. I asked the fellow to think about things more in a patient-centered way. When you're asking me, if you want to actually enhance your ability to deal with access complications and to enable, say, your structural heart career, that's different than really wanting to dedicate your life to the art and science of vascular medicine and intervention. So there's a spectrum of opportunity here, and it all starts with why. Dr. Abraham has already mentioned the center we put together, and when I came to Charleston in '93, it was a little bit hostile. The surgeons and radiologists all got together, really for the first time in a multidisciplinary way to push me from getting privileges. And so what I recognized early on is that yes, they brought a lot to the table, but my task was to how do we bring these people together to work together for the greater good of patient care. And so the initial concept of the Center of Excellence, as Ali mentioned, was all-inclusive in cardiology and vascular, but that couldn't herd the cats in cardiology, so I focused more on bringing us together in the vascular domain. And we had really simple criteria, but one of the things that made this work is our interventional suite. Once we got funding and I was able to get back support from the hospital, I put it in a neutral place. It wasn't in the cath lab. It wasn't in the interventional suite. It was on the second floor where all the surgery was being done. And it allowed me to cross-pollinate. So the other thing that I did was volunteered to scrub with radiologists, surgeons, anyone without charging them anything. They could bill for the cases, but to just imprint, and I found myself learning from them and giving them new tools like a stent that wasn't available before, or atherectomy and laser and different things that we brought to bear. So through my career, I've had the honor and privilege of training and working with the spectrum of people we're talking about today. I've founded and started an interventional vascular medicine fellowship. The requirement was you had to do an interventional year before coming. We did 2-year dedicated vascular medicine interventional sort of angiology fellowships with my good friend, Dr. Abrahama, who founded the vascular surgery fellowships and residency programs at our institution. I was on core faculty and able to scrub with teams there. And more importantly, found myself working with young faculty members that were passionate about the field of vascular. And so the key component and the really important thing that I want everyone to take home here is that everyone brings something to the table, and the key component here is a passion for these patients. So this is the center, and we were able to raise initially $40 million to get the COE model off the ground. And I will say Dr. Abarama coming on board was a really huge, really was the defining moment. And you remember, Ali, that our chair of surgery, Dr. Boland, made really was an important component of that vision. And so our center has grown now, and the movement has shifted more towards a vascular surgery focus, I would think, and that in part is driven by the fact that our vascular surgeons now are doing thousands of cases during their training in the endovascular space, and their reach is expanding in terms of what of that component. The important lessons for me in a multidisciplinary team and putting things together is that everybody brings something to the table. I think the contribution of the cardiologist should always be driven by why, what are their purpose, and how and that can be from the spectrum of, you know, the helping us deal with atrial fib and cardiac complications, to access issues, to the whole spectrum of really making a difference in our teams. We're seeing a lot of publications now with how multidisciplinary teams make a difference. One of the best examples in our institution is the heart team that Dr. Nanjandapa has founded and started, where we are on our structural heart side, bringing people in together as in a patient-centered mindset, and having disciplines work together is really important. But in the vascular side, there's, I think, relevant beachheads where we can pull teams together, including critical limb ischemia. Our PERT team is a combination of pulmonary critical care as well as our interventional colleagues. We have an acute stroke team. It's a different set of skill sets. And then the acute aortic syndrome team, I think, is another area of growth and where multiple disciplines are mission critical. The keys to success: patient-centered. The team has to be working together and put their egos at the door. Outcome and appropriate use transparency is important. So we don't want individuals doing inappropriate procedures or having heterogeneity of outcomes. Discipline and training requirements is important, depending on the purpose and the why, on why the individual's on the team. And I personally think that moving away from the fee-for-service model to an outcomes-based model is a really important and needed solution to some of the problems society faces in medicine today. How to become a meaningful contributor to the field as a cardiologist. If your why is that you really want to make a difference in this field and you want to be a key member of a multidisciplinary team, like Dr. Gray and some of the other individuals on this panel today, I think there is a list of things that are common sense. If you can't spend 3 years learning about the end organ of the heart and then do a weekend course to learn about mesenteric disease or renal disease. I hate to be flippant about it, but there has to be a combination of passion and engagement, because in the absence of that, there may be someone better that's to help care for those patients. One of the things we use in our cardiology fellowship is the guidelines that are published by the American College of Cardiology, called the COCATS guidelines, the core cardiovascular training statement. And these guidelines are particularly beneficial as you try to look at what should be done for specific privileging and credentialing. Most of them seem to be related more to the imaging side. Dr. Abarama, I don't know how your thoughts are on that. But if you look now, this is a really nice review. It's hard, when I read the guidelines, it's not that explicit on what the cardiologist should do to get in the game on the vascular interventional side. But this is a great review from Cornick and Reed in the ACC training pathways. And if you look at the vascular interventional suggested training pathway. It's a dedicated year in addition to 1 year of coronary intervention, which interestingly dovetails into our original Center of Excellence mantra. The next person we brought in, by the way, Dr. Nanjan Dapa, had trained with John Laird, and we're honored to have him on the team. This picture is actually from the last live case demonstration that Andreas Grunzig performed in 1980. Of course, he died in his plane crash in 1984. Most of us in the room realize that, or remember that Andreas is the person who brought us balloon angioplasty that took Charles Dotter's concept of dilating vessels to that next level. But I think the important thing in looking at this picture, a couple of my mentors are in this picture. I'm not circling them, but you see on the right, Andreas, but on the in the middle bottom side, you see Dr. Charles Dotter. Andreas really gave him a lot of credit for his contribution to the art and what led to his work. You see Sones, who in the second row back, who did the first heart catheterization, who also collaborated with Andreas. But more relevant to this discussion today, Andreas was a big believer in having multiple disciplines work together. He had angiologists and surgeons work with him as he did his first SFA angioplasty in 1977. He gave credit to a lot of those where he stood on the shoulders of those leaders in the past that preceded him and helped cultivate the art. This is an important lesson for us, I think, as we start to come together and really look where we can contribute and make a difference to, with moving forward. I'm going to thank Herb for providing this list of things. I wanted to get down to where are we doing well, and I know there's still and maybe perhaps appropriate turf challenges out there around the country, but we are doing things together, and I think Dr. Abrama, in your leadership position, I'm looking forward to seeing some of these things come to fruition. Multi-specialty guidelines, I think, and how we're working together in training modules for different people from different domains, looking at quality and outcomes. The presentation or study that you showed, Ali, is a great example. And I think the bigger upside is the advocacy side of coming together as you're going to accomplish more for the greater good of not only your society, but for patients with vascular disease. A great example there is what we dealt with when the FDA was challenging us about drug-coated balloons. And I really was blown away last year when all the societies came together, brought in oncologists and different people from different domains to address that important challenge or question is, do drug-coated balloons, are we harming patients? So I'm going to leave you with some thoughts. And this is a picture from the Heart House in Bethesda, where I think it's, as we look at young physicians who have a particular passion in helping vascular patients, it's really up to us to lend, extend a hand and help pull them up into this space and work together. I think together, forging the path towards making measurable differences in the lives of patients with vascular disease, I think that's possible. I think helping spark passion within different disciplines for dedicating careers towards the purpose of helping vascular patients is a worthwhile endeavor, and is really why we're all here. So again, Dr. Abrama, I appreciate your friendship. I appreciate your leadership in our community, and more importantly, congratulations on becoming president of the SVS. It's well deserved. Thank you.